going to talk about safety and protection tonight, which is patient handling skills, patient safety, including the teaching of caregivers. One of our big things is not necessarily to do it ourselves, but teach other people to do things. Like a child with cystic fibrosis, they need to have pulmonary drainage done every 4 or 8 hours. You need to teach family members, if you work in a school system, you need to teach the teacher's aide to provide that treatment for the patient, things like that. So there's a lot of education. Respiratory therapists are not trained to educate other people. They're only trained to treat the patient. And that's sort of where a line draws. You got a kid with cystic fibrosis admitted to the hospital, they may come down for treatment with the therapy room where you're teaching the parents how to do the treatment, things like that, which respiratory therapy really can't do or should not be doing. Okay, so really this is how to protect your patient. Make sure they're safe, make sure they're in a safe environment, which includes electrical, and really how to handle patients. How to deal with the IV lines, how to deal with the Foley catheter. Things like that are little details in answer choices that will make a difference. And there's about 10 to 15 questions on the exam here. So it's significant. On the PTA exam, it's close to 20 questions. So falls are a biggie. We see it a lot. It's what leads to, well, so the leading cause of accidental deaths in geriatric patients. 7th leading cause of death among people over 65. That's a huge number there. So it is terribly important. And falls, you sort of have to analyze, okay, why did you fall? What were the issues? Also, why patients don't do good. A geriatric patient really doesn't do great if you get them in a different environment, like going to a hospital, going to a nursing home. The risk of falls goes up greatly for really 3 to 6 months until they really adjust to it. And it takes them a long time to adjust to it. Mine, she still thinks she's up in Milwaukee with her sisters because she lived up there with her 2 sisters for like 20 some odd years. And she's still back in that time frame most of the time. Sometimes she's even back when she was 4 or 5 years of age. Once they fall, then they get that fear of falling, which even increases the risk of falling. Some things you can work on, dehydration, because that's going to cause orthostatic hypotension. Pressure sores, where they don't want to put pressure on something. They're a little bit more prone to hypothermia. They're prone to pneumonia. And if they're really deconditioned, they may be prone to rhabdomyolysis as well, which I think I am right now. Statin drugs is one of the big reasons that suddenly made it really prominent in the mid-90s when statins became really popular. CrossFit has caused a lot of that. You just overtrain so much that you're starting to tear your muscle tissue down. And the muscle tissue throws a lot of waste products out, and it can actually put you in renal failure, and maybe an irreversible renal failure. That's why you want to look at that CPK level. And if the level's going up, you definitely don't want to exercise them because they're having active muscle deterioration, and exercise would just even make it deteriorate more, and they'd end up getting weaker instead of stronger. I've sort of noticed that with my cancer, that type of issue, because really if the level changes, if it's going down, coming down towards normal, then you can exercise, but you want to make sure it doesn't go up again, because that means your patient's being overstressed. You always want it sort of going down. Falls, 40% of admissions to nursing homes. That's high. Cardiogenic is a big reason. Orthostatic hypotension, secondary to left-sided heart failure, those type of things come into play here. A patient that's just started on a calcium channel blocker, because a calcium channel blocker lowers your heart rate, also slightly lowers the force of contraction of the heart. And it takes the body about 2 to 3 weeks to learn to compensate for that. So you have that window where they're really prone to orthostatic hypotension. During the night, I would probably like to see a bedside commode, so they simply transfer over on a commode at night and they're not standing for any length of time, because it takes 2 to 3 minutes to pass out usually. But if you just stand up anaerobically and then get on the commode, you're not necessarily going to pass out. Also, I like a patient that, okay, if you're going to go to the bathroom at 2 in the morning, I want you to sit up and turn on the light in your room and stay sitting there for a good 5 minutes. Just if you feel like you got to go, commit yourself to going. Sit there for 5 minutes. Maybe do some long arc quads and things like that to get your blood pressure up a little bit more. Then after you're okay there, you're not getting dizzy at all, stand up by your bed and maybe march in place or something for a good 2 to 3 minutes. And would increase getting the blood pressure up. And I do have Irwin joining us.
Good evening.
Good evening.
I apologize for being tardy.
Only 3 lashes tonight. Have them march by the bed. If they start getting dizzy, where are you going to go? When you start getting dizzy, you plantar flex your feet. That throws your body backwards. So 90–95% of the chance they're going to end up falling right back in the bed again, which obviously that's a great place to fall instead of the floor. Very few patients will fall on their face, but usually you plantar flex your foot. That throws your center of gravity backwards, and you end up back in the bed, usually with no injury.
Will doing something like ankle pumps actually reduce the risk of orthostatic hypotension?
Any sort of exercise will stimulate the heart a little bit more and start getting that heart rate up a little bit, and also increase the force of contraction of the heart as well, so that anything pumps the blood pressure up. You may start off with ankle pumps. You may want to do heel slides. You may want to do straight leg raises. You may want to do marching in place when they're standing, long arc quads when they're sitting, knee lifts when they're sitting. Those type of things. The exercise gets the heart rate up a little bit faster. If you combine that plus the positioning, it makes it a little bit better to do. You can actually make one answer choice better than another. There are some studies on whites who fall have twice the hip fracture rate of other different racial groups. I think that's because a lot of white, particularly females, they didn't do a lot of manual labor. Their bones that's the group that tends to get more osteoporosis. So when they fall, they fracture. Whereas somebody had done a lot of manual labor throughout their life, their bones are a lot larger for that matter, and they're usually a lot more calcium in them. They have a tendency not to fracture as easily. And I do think we'll see that changing. I don't think that remains stable. I think if you looked at data from the 50s, you probably even saw a higher percentage of whites versus other racial groups. I think today they're starting to come a little bit closer together. 70% emergency room visits. I mean, a lot here. Usually it's cardiac and cardiogenic in nature, causing orthostatic hypotension that can lead to syncope. And they get the syncope when they're halfway down the hallway to the bathroom. And there's really no place to sit, there's no place to go to, and they end up falling. Then usually somebody finds them in the morning on the floor. Humeral fractures, particularly subcapital fracture, just right beneath the humeral head. It's like a compression fracture where the shaft of the humerus is put up into the ball of the humerus. It's a very stable fracture, but the rotator cuff is right around there too, and it usually disrupts that to some extent. Wrist fractures, particularly the Colles fracture. Colles means your wrist was an extension when you put it out to break your fall. If you ever see a Smith fracture, that's with the wrist being flexed. That gives you a hint the patient was unconscious when they actually fell. If you're conscious at all, you throw that wrist into extension to break your fall. But osteoporosis, intertrochanteric, probably one of the biggest fractures, is subcapital fracture of the humerus, that surgical neck area. It does involve the rotator cuff. Usually they're going to end up losing fairly significant shoulder range of motion as a result of that, but it usually heals pretty much without a lot of other problems. And then you see the Dowager's hump, which is anterior wedge compression fractures of the thoracic vertebral body. And the reason why it's the thoracic area, you don't see it in cervical, you don't see it in lumbar, but in the thoracic area, you have the articulation with the ribs there as well, the costovertebral joint. They support the facet joints as well and the vertebral body. So there's really a lot of external support to the vertebral body there. So the body demineralizes it by Wolff's law. If you don't use it, you lose it. And that's why you see particularly skinny old ladies getting this fairly significant thoracic kyphosis, which also prevents lung expansion. It also has a very much of a forward head. Usually you have trouble lifting the shoulders above 90 degrees, things like that, really associated with that. Obviously things that predispose stroke or TIAs. Parkinson's, the thing about Parkinson's is they usually fall forward because their momentum's going forward. They're really unaware of them taking so many steps, like a festinating gait. They're aware of their head moving forward in space more, which is the forward progress they're making. Now, they gradually have to take a lot of steps to make the same speed of movement and maintain the same speed. So they're still accelerating forward, but their feet aren't moving. They start to freeze up and they don't take any length of a step. That throws their center of gravity forward and puts them right in their face. And they tend to do face plants on you. Delirium, dementia, things like that would increase the risk of falling. Seizures obviously would. Seizures, again, they usually fall backwards instead of forwards. Myopathy is of different sorts, or just really muscular atrophy, contractures. The typical leg contracture is plantar flexion, knee flexion, hip flexion, but the plantar flexion throws your center of gravity back, and you have a tendency to go over backwards. The carotid sinus can get super sensitive or desensitive at all, so it doesn't trigger a higher heart rate when there's actually a demand for it, so the brain doesn't get enough oxygen, which causes syncope. And peripheral neuropathies are an issue. Cardiovascular, of course, MI. I would say causing orthostatic hypotension. I would also put in particularly left-sided heart failure, because left-sided heart failure congests the lungs, so even the blood going through the lungs is not being oxygenated all that well, and you have a problem. Also, too, geriatric patients are sort of borderline anemia. Normal hemoglobin level is about 12, but in an 80, 90-year-old, it's not unusual to see it getting closer to 10. And a little bit of problem could easily throw them into a true anemic situation. You also have cardiac arrhythmias. Generally, they're fast in the geriatric population, or they're very irregular, like the SA node is doing irregular pacemaking, where it may be like 120, 150, where the ventricles really don't have a time enough to refill completely before they're compressed again, and you don't get a lot of stroke volume out, and the blood isn't carrying that much oxygen anyway, and you have some problems there. But it's not unusual to see fairly fast arrhythmias. Sometimes they're sinus arrhythmias where you actually have a P wave to it, like atrial fib and things like that, although atrial fib's unlikely to cause much of a problem, because if you really even have both atria totally in fibrillation, you've lost about 10% of your heart pumping function, which usually is not significant. GI system, you see bleeding in there. You can have it after hemorrhoids, because they can bleed fairly significantly. Older patients tend to have more hemorrhoids because they get really constipated. That irritates the wall lining and causes the hemorrhoid. Diarrhea, they lose a lot of potassium, retain a lot of sodium, so they have a sodium-potassium imbalance going on. Defecation syncope, when you have a bowel movement, you definitely have a fairly significant Valsalva to it, and particularly if you're constipated. So you see that more commonly in your geriatric populations. Postpyramidal syncope is coming with the crossing of the sensory and motor nerves up in the brainstem. Metabolic, you got hyperthyroidism, the diabetes. I would put anemia more in cardiovascular. Hypokalemia, which is high potassium level, that makes you really weak. Dehydration, geriatric patients there's a fine line and they get dehydrated fairly easily. Actually, young children and geriatric patients both get dehydrated really easily. And sometimes they urinate too much and they drop their bladder fluid down too much. Definitely incontinence being an issue. Micturition syncope is the urine coming from the kidneys through the ureter to the bladder, And if that's overproduced, you're taking too much fluid out of your system, even though once it gets in the bladder, okay, but you can't really absorb it back very easily. Deconditioning is a big problem with geriatric patients. I would say the stiffness too, because as you get older, your elastin fibers in your tissue, particularly muscle tissue, is replaced with collagen, which is relatively inelastic. And you can't feel a little bit of pressure change. You can feel a lot of change, and you almost get too much sensation from it, and your brain sort of detunes to that, so it doesn't react to it as much. And that can really lead to somebody not feeling enough, causing falls. Balance is a mix of proprioception coming from the muscles and the joint tendons and the Golgi tendon apparatuses and things like that. You can have vestibular problems coming from the inner ear. They're actually fairly rare. The stiffness is what's very consistent, and that gives you that lack of feeling. You can't feel small changes. You can only feel large changes, like when your center of gravity is way outside of your base of support, then you feel it. And that's a little bit late. You're already going down for the floor. Arthritis. I would say osteoarthritis more related to age, whereas rheumatoid is more of a disease process. But rheumatoid will cause some osteoarthritis as well. And you start seeing some proximal weakness too. It's in the core, it would be in the shoulders, it would be in the hips, not so much the knee extension or the ankle plantar flexion dorsiflexion issue, but more the central muscles get really weak, which means you're not getting, in the lower extremity, you're not getting consistent foot placement, and you're starting to shuffle. And I think we've all seen patients shuffle a lot. And shuffling, the patient just doesn't want to lift the leg up. It actually takes a lot more energy to shuffle than it does to walk normally. You have depression and you have anxiety. Both of them really affect your concentration of what you're doing and can lead to more falls. So really to intervene here, try to have safe environment that they're working in. You always want hallways and things like that, walkways wide enough that they can easily turn around. Rails really help. You don't want a lot of floor clutter. Like throw rugs, you step on part of it, it just slides out from underneath you. Now, if you got a throw rug that's got a rubber backing on it, it's maybe not going to move that much. And I do not go, when I do home health, I do not go in a patient's house and remove every single throw rug from the house. I may remove the ones in the area the patient's usually walking in. I may want them to take those up. Otherwise, no. Exercise, really range of motion and strengthening are the two things that's going to sort of prevent falls exercise-wise. The stretching is really important to get that proprioceptive sensation back again, because proprioception is a big part of balance and probably most likely the problem. Vestibular, probably number 2 on the hit parade there, and number 3 would be visual, but visual is almost a correct compensation technique that you can throw in if vestibular or if proprioception isn't working very well. And using geriatric patient, proprioception is not working very well, so they will use a visual compensation to correct for that. So having the lights on, getting used to the light, because geriatric population, the pupil doesn't change size as quickly as it normally should to accommodate the amount of light in that environment. So going from a light to a dark place, they won't have good vision for a while till their eyes adjust. And it's going to take 2 to 3 times as long for their eyes to adjust to that lower light level. Or going from dark to bright, again, they have trouble adjusting. More of a consistent lighting would be probably best. You also want things like tables and plinths and like coffee tables and things like that. They're not really in your visual field that easily, and they don't see them. They're looking straight ahead, but they don't see that thing about shin high or knee high. They see from basically mid-chest up is where their focus is more directed. So sometimes taking coffee tables away for a little bit or something like that, trying to clear that space in between so they don't trip over it. Plinths are also low enough where they're really out of the visual field. They can see if they're looking for it, but generally no. Electrical, Electrocutions do happen, and we want to try to eliminate them as much as possible. Direct current is more likely going to cause an electrical burn, whereas alternating current is more likely going to cause a thermal burn. House voltage, stuff like that, is all AC. We probably don't see a lot of DC burns, environmentally acquired, but we do see a lot of AC burns. Geriatric, particularly a confused geriatric patient, or young children are very susceptible to electrical type burns. The electrical current is also known to cause both seizures and cardiac arrest, and cause asystole, and could cause ventricular fibrillation. Extension cords, number one, they may fray and short out and cause a fire pretty easily. If you just keep walking over the cord, you're going to bust some of the wires inside. They'll eventually lose their insulation. They'll start making contact, and that would start a fire. You do not want to use a lot of extension cords. And boy, I've walked in a few home health houses, and there's extension cords all over the place. You want to try to stay away from that. If you have to use an extension cord, it probably is best placed right around the wall so you're not stepping on it and busting the cord itself in the middle. You also have to make sure the plugs are all intact and things like that, and they're not pulling things out by the cord. They're actually pulling the plug out instead, because you'll see the plugs start, the wires starting to get pulled out of the plugs, and that can cause fires. Therapy clinic, there really should be a weekly inspection. Some states require a quarterly inspection by a certified technician of all electrical equipment, and that's really best practice. They look for the safety of the equipment, like it's not going to short out. They'll check the plugs and things like that with it. They also usually calibrate, like the ultrasound and those things, and the electrical stim. So if it says it's giving you 30 milliamps, it's actually giving you 30 milliamps. A hospital would have probably a certified technician that does that with all the hospital equipment. Usually about every quarter they go through and check all the machinery out. And if something's broken, you really want to take it. When you don't see it, you're not going to use it. So you try to put it away in a spot that gets out of the normal pattern of use. And you like a sign on it saying, do not use this until it gets serviced. Out of sight means out of mind as well. So out of sight is probably number one. Number two is a sign. Water is a great conductor of electricity. So you really want to have like a ground fault interrupter circuit, which is like an extra circuit breaker. And if there's a short in there, it shuts the current off. Anytime you have water near electrical outlets or something like that, it should be a GFI outlet. So a plug by a sink should be a GFI. If you have a hydrotherapy room, all the whirlpools should be attached through a GFI to the wall current. You can have, some modalities are galvanic, some are faradic, which is AC, and galvanic is DC. They will use those terms on the exam. Galvanics use a fair amount in practice, more likely on the exam, but faradic is a term for AC. We don't use it a lot, but it can be used. Anode and cathode is something you need to get down your head too. And the way I remember is I hate cats, so they're negative polarity. I don't really hate cats, but I like dogs better. But the direct current versus alternating current, there is a difference between female and male. Females have more subcutaneous fat, which converts the electrical current into heat more than males. Young children, toddlers, have very little fat there, so they don't really feel the sensation of the electricity nearly as much as adults do. Skin irritation usually occurs around the positive pole because the pH there is higher. It's more alkalytic, and the body really doesn't tolerate alkali at all, or a high pH. Good example is diabetes, because hypoglycemia leading to insulin shock is low blood sugar, but it's also high pH. The body's fairly intolerant of that. A low pH, the body's more tolerant of, and that would be true with even hyperglycemia. You really don't see symptoms until about 250 to 300 usually. Symptoms just don't present until then, which it should be down around 100, 120. That's a fairly good distance. you start getting critical, like 500 to 700 milligrams per deciliter of glucose in your bloodstream. But on the low end, below 90, they start getting symptomatic. And below 70, it can be lethal, causing seizures or ventricular fib. So the body really isn't tolerant of the high pH or the alkalytic condition as much. Much more tolerant of the acidotic condition, actually. This making some sense to you guys?
Yes.
Now, do you have to know these milliamps for the exam? Maybe. Although I doubt the question is going to hinge just on the milliamp alone. But you got respiratory problems because any current crossing the chest can affect the phrenic nerve, and that affects both the depth of ventilation and the rate of ventilation. Again, crossing the heart too, it can either, if it's fairly high intensity or high voltage, it could actually stop the heart muscle and throw them into a systole. It can also cause the heart to go into VFib. That's really what the macro shock is all about. And electrical burns, about 250 microamps is enough to start causing electrical burn. E-stim can be used in pregnancy and labor. The problem with electrical stim is that it can trigger labor to start, and you don't want to start prematurely. But once labor has started and you want it to continue, then you could use electrical stim. And actually, electrical stim will cut the labor time down, cuts it about in half to a third, which is quite significant, which reduces your risk of CP and other problems, because a baby with a long labor, the fetus is being compressed a lot. You got more anoxic problems occurring and things like that. It doesn't really have, the electricity probably isn't going to have much effect on the fetus. A baby with severe brain damage and even having a lot of seizures in utero, yes, in that case it would, because it could trigger seizures in the child, which you wouldn't want to do, but that's really unusual. And I think cerebral palsy really is related to the anoxia, and there's a fairly strong correlation with prolonged labor and cerebral palsy as well. And it's quite strong. And that's more likely to be the issue than the child having seizures. Until the baby's born, you really don't know. But your bets are going to be more that it's probably going to decrease the risk of problems to the child. I usually start them with a bipolar in the low back, particularly concentrating on L1, 2, 3 and the paraspinals back there, because pregnant moms usually have a very sore back to begin with. Electricity has been known to cause seizures, but seizures, somebody has a threshold of a seizure. If they're known to have seizures, they're probably on a drug like Dilantin or phenytonin. I would really want to check if somebody has a history of seizures, a very recent, like right before I did electrical stim to them, of their Dilantin level in their bloodstream. And if it was within the therapeutic window, it's unlikely that the electrical stim would cause a seizure. High-intensity exercise can also cause seizures, particularly if somebody's close to having one anyway. So again, maybe drawing a Dilantin level or something like that may tell you what you can do more safely. And PT's starting to go there with those type of things. It's definitely supported by research, and the evidence is supporting it. Sodium and potassium balance, really important. If your sodium's up really high or your potassium is too low, really the ratio between the two is out of whack. High sodium increases nerve conduction velocity, which also increases the risk of seizure. High potassium, on the other hand, slows everything up. It slows the nerve conduction velocity. They're very unlikely to have seizures with a very high potassium level. But it's really the ratio between sodium and potassium that determines that. You will have probably several questions that get into the sodium-potassium level on the exam, because in electrolytes, that's probably the most important. Now, calcium, if it's high, it causes the release of more sodium. So high calcium levels will actually boost the sodium level up. Too low calcium, you'll actually see a drop in the sodium levels. But it's the sodium-potassium balance that's actually causing the problem. Dilantin and phenytonin should be two drugs you know. They're both used. Tegretol's the other one. They're used to control seizures. Phenytoin is a generic name for Dilantin, but Tegretol is a different drug. I don't think you'd hear the generic name for that, but Tegretol you might. Tegretol doesn't cause the gum problems that Dilantin does, because Dilantin causes some pretty bad gingivitis of the gums, whereas Tegretol is less likely to, although Dilantin's probably used more. Temperature can be a difference. You can stress a patient with either high or low temperatures. Temperatures over 9 degrees particularly, even when it starts getting over about 75 in a pool, which conducts a lot of the temperature to the body and takes heat away from the body a lot. Our body's producing, particularly if we're exercising in a therapeutic pool, we're raising our core body temp, and you got to have that temperature removed. You wouldn't want to exercise in a 105-degree pool that much, because you'll really get zapped by it. 80 degrees in air. So when it starts getting over 80, you need to start worrying about dehydration. Probably geriatric patients shouldn't be out for any length of time when it's over like 82, 85 degrees. Temperatures less than 20 degrees can also cause a problem. That cold air hitting your bronchus and your trachea, particularly the bronchus, can cause bronchial spasms. The bronchioles can go into spasm and trigger an asthmatic attack. So if it's really cold out, like it is in Buffalo or Chicago during the winter, wearing a muffler over or a mask over, that will pre-warm the air, because when you exhaust, when you exhale, that's warmer air. That'll warm the new air coming down, so you don't really have that problem as much. And actually getting patients to wear masks or a muffler over their face to try to pre-warm that air up before they're actually taking it down in their lungs may prevent really sort of like an asthmatic attack. So cold temperatures and hot temperatures. Definitely heat, you got a dehydration issue to it. Older patients really can't tolerate large temperature fluctuations. Frostbite actually can start with prolonged exposure of 45 degrees, particularly in water, where you're taking a lot of the heat away from the body. Air, not so much, but water definitely. IVs, they regulate the rate of dosage of the particular drug that they're infusing you with, and they're pretty well regulated there. They can alarm on you where if you're doing exercise with your patient, you increase a lot of the pressure inside the veins. That could be interpreted by the pump as a blockage, and it may shut off and alarm on you. If there's air in the line, they can alarm too. Actually, if a lot of the air coming through the IV tubing actually gets in the patient's bloodstream, that can cause air emboli, which can end up causing things like stroke, or particularly it's more likely to cause a pulmonary embolus, because it's going to go through the right side and end up in the lungs more likely. But they do a lot better, the pumps do a lot better regulating the dosages. Before we had pumps, we actually used to elevate the bag so much over the patient's arm, and you look at the drip rate, how many drips per minute they're getting. That gives you an idea of what type of dosage they're getting. But if you elevate the arm, then you change all those ratios. So you really didn't want to elevate or depress the arm that had the IV going into it. You also didn't want to exercise a lot, particularly isometric exercise, because that would block the blood flow and increase the pressure inside the vein and decrease the amount of drug being administered to the patient. If you elevate too much or decrease too much, the pressure inside the vein gets to be greater than the pressure of the drug coming down through the IV line, and you start seeing the IV line start getting filled up with blood, and is a positional effect. You don't see that quite as badly with the pumps, and that's one of the big reasons they're used a lot. Geriatric patients have a tendency to have really fragile veins, and they tend to blow out really easily. It does need to be addressed, but the first thing to do is to shut it off. The second thing is to get nursing to take the IV out and do another venipuncture and get the IV reestablished. But that could be done 15, 20 minutes later after you're done with your exercise. Central lines going into like the subclavian or something like that vein, which is a big, huge pipe, they are surgically placed. And if they come out, you're likely to have hemorrhage from that vein, and fairly significant hemorrhage from that vein. It's actually a medical emergency when these are pulled out. So if somebody had a central line in, like a Hickman or something like that, the catheter tips may actually go down to the superior vena cava. Definitely shut off the pump and things like that, but also I would activate the emergency medical system, because they could hemorrhage out, they could hemorrhage into the pleural space, that could end up collapsing a lung on them, really going to cause a lot of that internal bleeding. It's not going to be, you're not going to see anything on the surface, but they're bleeding down deep, and they really have to surgically go in, maybe even suture the subclavian, maybe put it in the, if it was in the left subclavian, they may put a new one in the right subclavian, which is a surgical procedure. They're usually sutured in place so they don't pull out all that easily. But if somebody has a central line, you want to make sure nothing's pulling on it. If it's an IV, if it pulls out, yeah, they need another venipuncture. If it's a central line that pulls out, they need emergency surgery. Dialysis ports, PICC lines, they're usually in the forearm, they're usually in the radial artery a lot. PICC lines are usually, if they're not using it, they'll instill a little bit of heparin to prevent the blood from clotting in there. One of the big problems is they do start filling up with thrombuses and start to clog up, and sometimes they can open them back up again with heparin and saline, sometimes they can't. I find a lot of diabetics, or not, a lot of patients on renal dialysis, which a lot of them are diabetics, they may start off with a AV shunt in the radial artery. Eventually that'll blow or clog up too much where they can't use it anymore. They'll put a new port in the opposite arm radial artery. If they have a PICC line or a dialysis port, you do not want to take blood pressure in that arm, because you would slow the blood flow down. That would possibly clog up the port or the PICC line. You also do not want to do isometrics in that arm. You could do isotonics, but you want to make sure that the speed of movement is normal to fast. You don't want to have a really slow movement, and you don't want to use a ton of resistance. A ton of resistance will give you a slower movement. That slows the blood flow in the area, more likely to allow clots to form. Again, taking blood pressure, you're occluding the veins. That's going to cause that blood to just sit there and start to clot too as well. And that's why you don't do blood pressure in that arm. You probably also won't get a good radial pulse on that side when they have a port, because the port's in the forearm. Distal of that, their pulse would be fairly significantly diminished, and you might not be able to feel it. So I would take the pulse in their other arm instead. So if they have a port in the right arm, when I'm monitoring vital signs, I'm going to take the pulse from the left radial artery, not the right. I'm going to take blood pressure from the left brachial, not the right. Nasogastric tubes are used for a lot of things. There's nasogastric and there's G tubes. Nasogastric, usually a temporary thing. It's through the nose, down the back of the throat. It should go down the esophagus, not the trachea. Sometimes hard to do, but it should go down the esophagus instead. They should be trying to swallow as you're sticking the thing in. That'll direct it more down the esophagus than it will the trach. You can add nutrition through an NG tube, or you can put suction on it and empty the stomach through the NG tube. And they're used for both. But using NG is something you'd use for maybe 5 days, maybe 10 at the most. If they need something longer than that, then probably a G tube is a better choice. G tubes actually work fairly well on infants, because they don't even know that that's part of them, where the G tube is, so they really don't tend to pull on it too much. An adult dementia patient, they may pull on the tube. They're more likely to pull on the tube. An infant really is aware, basically nipple line on up around their face, but they're really unaware of the rest of their body. So you can get away with G tubes fairly easily in those kids. The G tube, gastric tube, is used, it's usually a percutaneous thing where you just punch it in. You can palpate the stomach fairly easily and punch it in. Some doctors may stick a scope down the esophagus so they can see it come through, but what I've seen with most docs, they don't bother with that. that you can palpate the stomach pretty easily. You don't want a patient pulling on it. Abdominal exercises you would want to hold for about 10 to 14 days after the insertion of a G-tube. You could exercise the extremities all you want. You could probably exercise the back extensors. You just don't want to exercise the abdominal wall at all, because you want to really let it heal around the wound, to heal around the G-tube. And it'll actually form like a hole there from the stomach to the surface. And they usually use really just like a Foley catheter. It's got a little bulb on the end of it that holds it in place, prevents it from pulling out. The bulb is filled with saline, so they inject it with saline to fill the bulb up to hold it in place. If you got a patient on G-tube feedings, if they've just started on it, usually they get so many calories per hour. If you want to take them off to be able to lie them down flat, if you keep them elevated, there's probably not that big of a risk. If you wait about an hour and a half, 2 hours after eating, or after they were last fed, or if they're on a constant feed, probably not that big of an issue. If they give them a lot of G-tube feeding all at once, it causes diarrhea fairly easily. And not all patients will develop the diarrhea, but a lot will. Over time, what they're going to do is try to take that constant feeding and increase the concentration a little bit, but then stop the feeding periodically to give them some breaks from it. And eventually they can get down to the point that they're just taking a syringe, putting the food in through the syringe in the stomach like 3 times a day to imitate breakfast, lunch, and dinner, and that would fill up the stomach. You need to consult with nursing before you discontinue the G-tube, because they have to make sure the patient's getting adequate calories. You'd want to discontinue the G-tube like 2 hours to allow the stomach to empty and get all the abdominal or all the stomach contents below the pyloric sphincter before you would lay them flat or something. You definitely wouldn't want to put something with a G-tube in a Trendelenburg position with the head down. But even flat or supine or prone, you would want the stomach totally cleared. In adults, that's going to take about 2 hours. So they're off the G-tube feeding for 2 hours before you treat them. Then you spend time treating them about an hour. Now they've been off for 3 hours. That's a lot of calories that they're missing. So nursing and nutrition has to reevaluate that and probably increase the feeding rate to try to make up for the difference. That's why this really has to be done in conjunction with nursing. Oftentimes also the nutritionist may be consulted as well, but you can't suddenly increase the amount of food they're getting through the G-tube either. Otherwise they get diarrhea and don't only absorb a lot of the food being given them, and you end up with a malnutrition situation. Trachs, it shortens the airways very significantly. Most of the time when we breathe in through our nose, and the turbines in the nose warms things up. There's also a fair number of white blood cells in the area that could also prevent more of an infection and start to kill off any infection coming into the body. Most of the air we inhale is usually through our nose. We can inhale it through the mouth, but then we don't get as much of an infection prevention as we would through the nose. The nose is also going to warm the air up more, so by the time it hits the trachea and hits the bronchus, it's closer to normal body temperature. You don't have a huge temperature change. A trach tube really does away with all that, but it also increases the resistance also. You have to breathe a little bit harder to pull in the air through the nose than you would with a trach. So a trach is going to give you better lung inflation and things like that. It's usually placed right above the thyroid gland, and there's a little cartilage there. If you look at the pulmonary anatomy, there's one graphic that really has that area of the body fairly well detailed. The larynx, the trach, the cricoid, the cartilage, things like that. And it's right below the cricoid. It's actually right below the thyroid cartilage, which would be the soft area to get into. You also don't want to hit the thyroid gland, which wraps around the trachea too. You want to avoid that when they place one. Sometimes with pneumonia, you want to have better inspiration, they'll put a trach in somebody. But when you got a trach in, you're more likely to get infections like pneumonias because you bypassed some of the body's ability to deal with that infection and try to prevent that. You can also suction through the trach. If you're ever working with a patient with a trach, you should be always prepared to suction them because you could just roll them from like supine to side-lying. A whole bunch of sputum will start blocking the bronchus and start blocking the trachea, and they need to be suctioned. So when we're working with patients with a trach, be prepared to suction them. And suctioning is something that should be taught in all PT and PTA programs. Often it's not, but that emergency area where they actually plug up just due to changing their position happens a lot during PT, and you may need to suddenly clear that sputum. Now, we wouldn't do suctioning every 8 hours or something. Nursing or respiratory therapy may do that, but we're going to do that just to keep the airway open if it occludes during our treatment session. When patients have monitoring devices, you may need to make sure they're working properly before you start with them, because that's how you're monitoring them. If they have an EKG, like telemetry or something, make sure it's functioning okay before you start working with them. You need to have a baseline to work from as well. Pulse oximeter, O2 sat readings the same way, because you're going to see changes, particularly in the O2 sat, fairly quickly if anything's going wrong. O2 saturation going down doesn't really tell us what's going wrong. It could be pulmonary, it could be cardiac, but it tells us something's going wrong because the distal tissue is not getting enough oxygen. Oftentimes they may do an arterial blood gas test to just see how accurate their pulse oximetry is. So they take an ABG, look at the reading from the O2 sat, document that. It usually takes an hour to 2 hours to get the ABG, the blood gases, back from the lab. You don't get that instantaneously. And you can see if the pulse ox is reading a little bit low, pulse ox is reading normal, fairly accurately, or that with geriatric patients with a lot of atherosclerotic disease, you often see the pulse ox reading abnormally low, but their ABGs could be fairly normal. Their arterial blood gases could be relatively normal. Oftentimes, too, with O2 sat, we're looking at how it changes. Generally, with a fairly critical, unstable patient, you really want them to be about 95% O2 sat or above. Working with patients in general, we usually don't want to push somebody to drop their O2 sat below 90 during exercise. If it's below 90 at rest, that's an indication they need O2 supplementation. Foley catheters, urinary catheters, if it's an indwelling Foley, they're usually changed about once a month. And every time you stick a Foley in somebody, you're likely to stick some bacteria in with it. So you don't want to change it all that often. You don't want to have to recatheterize the patient on a consistent basis. Spinal cord injury, if their urinary collection bag is full, you're about ready to start treatment, you really want to get the thing emptied before you really start treatment. Nursing often measures output, so you may drain the bag, but you need to drain it into something that'll give you a measure of how much urine, and you need to be able to document that so nursing can keep a track on input-output. But you also don't want to take them down to the gym with a really full bag, because those bags are more likely to spring leaks and things like that, and that's a total mess. Oftentimes, like an outpatient might be using a leg bag, and they don't hold a heck of a lot of urine. They hold probably a pint, whereas a Foley bag, quart and a half. You also want to keep the bag below the bladder height, but not on the floor. The floor is the most bacteria-rich area because just due to gravity, bacteria collects on the floor. So you have a lot of bacteria there. You want to be probably about 4 to 6 inches above the floor. And then your amount of bacteria in the area is actually significantly less. You also don't want to have it above the bladder because then you get a retrograde flow from the collection bag back through the catheter into the bladder. There could be infection starting up within that collection bag, and that infection would be added to the bladder at that point and increase the risk of a UTI. So you always want to keep that collection bag lower than the bladder, but not on the floor. If the Foley comes out, and sometimes patients will say, oh, I feel like I wet myself. What happened was a little balloon that holds the tip of the catheter in the bladder, that saline has, the valve has somewhat come open, allowing the saline to come out of that little balloon in there. That'll go down their leg and it feels like they wet themselves, but it also means that Foley can come out really easily. It can almost, as you stand them up, they can fall out sometimes, particularly if a patient's been catheterized a lot or has been catheterized for a long period of time, because the urethra sort of grows around the size of the catheter. Now, if they're initially catheterized, the urethra usually constricts very much to the catheter tubing. But if it's been there for a while, it tends to get a little bit away from it, and they tend to fall out easier. But really only if that bulb that holds it in place is not inflated. If a Foley comes out of a patient, it can be replaced when the treatment finishes. Do your treatment, then get nursing to replace it, and then have to recatheterize the patient to do that. That's not something that would be in the scope of a physical therapist. That's definitely in the scope of nursing. Oxygen equipment, we see portables like this a lot. You can have a mask or you can have a cannula. Cannulas are more common. They really don't block your ability to talk, but you want to have the pins all tight in there when you're starting to move somebody. Liquid oxygen, you don't really want to have it tip over, because that liquid oxygen is super, super cold. And if that hits your skin, it's definitely going to cause a frostbite issue. Oxygen itself is not flammable, but if something else is burning, that high oxygen level in the environment is going to cause it to burn all the faster and create all the more heat. D-tank is usually what's used as a portable cylinder of gas. E-tank's a little bit longer. It holds a little bit more oxygen, holds about a third more oxygen in it, so they can go, it'll last longer. There's also a whole bunch of liquid oxygen things, even portable concentrators too, which actually are battery powered, and they do electrolysis of the air, and they separate the oxygen from the CO2, collect the oxygen, and administer it to the patient. And those are battery operated things. They also have concentrators that are really fairly large, and they're set to the wall, and you would position one where the patient's sitting all the time, like by their easy chair or by their bed. I've seen patients have a couple, or they can just move the one because they're usually on wheels, but they're usually fairly large and bulky. But there are some portable ones as well. A nasal cannula has the two little prongs that go up the nose. You can deliver about 2 to 3 liters of oxygen with that. Really not much more, because your nasal cavity can only accept so much. Venturi mask is a mask, got a few little holes for exhalation in it, but that can increase the oxygen delivery to about 4 to 5 liters per minute. Then there's a rebreathing mask that has this little bag beneath it, and during exhalation that bag will start going up a little bit and then down a little bit. It concentrates the oxygen more, and the mask really doesn't have any holes in it at all. So you're delivering around 10 to 12 liters per minute if you're using the rebreathing bag. Now, as far as the PT goes, the cannula is the most common. And if they're set on 2 to 3 liters per minute, maybe on the wall, and you want to get them on a portable, you would set the portable to 2 to 3 liters per minute. You just match it. Increasing oxygen content really doesn't help performance as far as physical activity goes. It may improve recovery time to some extent, but it doesn't really help performance at all. So, increasing the liter flow because they're doing more activity really isn't going to have a significant effect at all. It's really not going to change anything. It's how long they were on it for a long extended period of time. Some patients may just use the oxygen overnight, may not use it during the day. What they do is replenish their oxygen stores in their body fairly adequately during night, and then they can use that oxygen, that extra oxygen during the day. Oftentimes they need it on all the time, but sometimes patients will just use it at night like that to particularly do an anaerobic exercise where your muscles are recharging at night and they're using oxygen to recharge themselves and create more ATP. Using it at night would be a great idea because it would support that development of more ATP to be stored within the muscle groups. Aerobic exercise, they're burning oxygen as they're exercising, so that patient probably needs to be on oxygen. Where the stopcock valve meets the tank, there's an O-ring, and that's sort of a softer plastic. You can screw it down really tight and provides a seal. So every time you change a tank, you probably should change the O-ring as well. And the oxygen concentrators, they use that electrolysis process to actually produce oxygen in a higher concentration from the room air. Also, too, oxygen from a tank or liquefied oxygen, very, very dry. It's best to put a humidifier there, which is like a little container of water that the air or that the oxygen bubbles up through and absorbs some of the moisture. That actually helps with the absorption of the oxygen too, because if it's really dry, you don't absorb a heck of a lot, but if it's moist, you absorb a lot more. It also prevents irritation in the nasal cavities and the lungs as much, so that humidification really is something that should be done. There are disaster plans for all licensed medical facilities, and they actually have to write these fairly elaborate procedures, and they have to test them periodically to see that their employees are complying with the protocols that they established. So you have fire alarm drills and things like that. They would include things like earthquakes, particularly if your facility is in a fairly earthquake-prone area. Fires or explosions is something that would be part of it. You will hear of a fire in a certain room over the internet or over the loudspeaker. You want to stay away from that room. I would not move a patient towards where the fire is. I want to move them away from the fire. I also want to close all the doors in the area to try to confine that fire to a smaller part of the facility. So closing doors are number one, evacuating patients may be number two. You'd probably get an evacuation order through the intercom as well. If there's a fire that cannot be easily controlled, you may want to put the fire out. If you don't have a patient with you or something like that, your patient always comes first. But if you don't have a patient with you, you might want to use a fire extinguisher. Electrical fires need to be a chemical extinguisher or CO2. CO2 takes away the oxygen that would stop the fire, but it also cools it a lot, so it would cool down the thermal elements. Water will actually, if you put water on a grease fire, it would actually spread the fire because the fire would be on top of the water that way. So you wouldn't want to use a water extinguisher on a grease fire of any sort or an oily fire. Water probably would not be a good idea with an electrical fire either, because now you've made the floor conducting and you've increased the area that could cause an electrical burn or electrical shock. Again, you'd probably want to use a chemical type extinguisher. Most of the extinguishers I see in facilities are chemical, because a chemical extinguisher would probably work on just a regular fire. It would probably work on electrical and would probably work on an oil-based fire. CO2 may be good for electrical, may be good for an oil-based fire, would not be the greatest for just a normal fire. Water may be best because it heats up, it starts to go away and takes a lot of the heat out of the area with it. As the water converts, gets high enough and starts going off as steam into the environment, but that'll take a lot of heat with it. Hazardous materials. In medical facilities, there's a lot of hazardous materials, including nuclear waste from radiation therapy and things like that. So you need to be sort of aware that that's there. Again, you'd want to stay away from it if there's a leak or exposure of it, and you'd actually hear it over the intercom. Usually each facility has their own little codes Like Dr. Red could be a fire in one hospital. Dr. Red could be a medical emergency in another medical facility. So they're really developed, these disaster plans are developed pretty much by each facility itself. They come up with slightly different protocols. There's no one standard protocol to use. Extended power outages and utility outages, there's contingency plans there. Usually medical facilities have a generator that will not supply all the electricity to the facility, but would provide enough electricity for the refrigeration units, for the ventilators and things like that that are more necessary. They're usually red tagged outlets that would be tied to the generator. They would be on normal power when the power is normal, but if they go to generator, they'll still receive the electricity from the generator. The other wall outlets probably won't receive any electricity if there's a power outage. Floods can be producing a lot too. Occasionally they have to evacuate places. We had some flooding a couple months ago in Chicago, and they had to evacuate one hospital, and they evacuated for about a week. There's mass casualty events, bomb going off or an airplane crashing with a lot of injured patients. If they're all dead, no. But if there's a lot of injuries coming in to a fairly limited number of facilities, it can sort of overwhelm the staff there. Oftentimes, you're delegated a certain job to do as far as mass casualties. So you wouldn't be working as a PT anymore, but you'd maybe be transporting patients from the parking lot into the ER room and then from the ER room to other places within the facility. You're given different job descriptions to do in the event of a mass casualty event. You should know all these protocols before you walk into that facility with a name tag on that says you work there. As soon as they hire you, they should give you disaster plans so you can know these. And I've seen JCO reviewers and things like that coming through. They're doing a JCO review, which is usually a yearly thing. State review from the State Board of Health, which really does the same thing JCO does. Maybe not quite as intensively as a JCO, but it's the same sort of review process. They'll walk up to somebody who was just hired and says, what happens when you hear Dr. Red over the intercom? What do you do? And they'll quiz you on it. And if you don't know it, that hospital is going to get that facility is going to get a huge fine, because you should know that as soon as you're an employee there and are acting as an employee there. That's why they really should give you this as soon as they have decided to hire you and you've signed your contract with them. You should go home with the disaster plans, pretty much memorize them, their protocols. You follow the protocol. They're all different, every facility. They're going to have sort of the same ones, but there's going to be different details per facility because they develop their own. Infection control, bloodborne pathogens like HIV, hepatitis B. These are blood to blood. So if you have an open wound, yeah, you could possibly pick up an HIV through your skin opening, which if the skin is closed, it's a barrier to it. But once that barrier is defeated, then you're more at risk for it. Hepatitis B and C, I should have put C there too. Certain viruses are there. There's different types of isolation, like contact isolation, respiratory isolation, droplet isolation. There's different types of respiratory things that are used for different types of diseases. Tuberculosis really it's fairly common and has a lot of isolation techniques you have to follow. And dealing with some of the, not Zika, but Ebola was a good example of something where you really have to follow the isolation precautions exactly. And as soon as it's diagnosed, those precautions go on. And if you sort of suspect it, probably you should start doing the precautions. SARS may be another one of those that would be there. Those are really respiratory ones, and the respiratory are probably the hardest. Contact isolation is just if they have an open oozing wound or something like that. You don't want to be in contact with it without a barrier in there, like gloves or something like that. You want to try to keep it covered at all times. Number one way to reduce infection, hand washing. That's the most common reason for cross-contamination from one patient to another. You always, between each patient, you would want to wash your hands. Even if you don't glove them, you at least want to wash them. You usually start off with soap is better than anything else, but there's antimicrobials and things like that, soaps that you can use. You really want to rub them vigorously for at least 10. Some recommendations I see in the literature of 20 seconds with the soap. Start off with warm water, then you follow with a rinse in cold water. That hot to cold removes more of the contaminants, so it's actually better. Even if you're doing a patient with a couple wounds, each wound could actually have different pathogens in it. So I would treat each wound like a different patient. I would finish wound one, actually I'd take the dressing off, throw them away. I'd scrub myself first and put gloves on, remove the dressing, put it away get it off, bag it, and dispose of it properly as per protocol. Wash my hands, put on clean gloves, apply a treatment or the new dressing, and washing the wound. Then I'd want to take my gloves off, wash my hands again before I take the second dressing off. And then wash my hands again, take my gloves off, wash my hands again, put new gloves on before I put the new dressing on the second wound. So you treat each wound almost like a separate patient, because one wound may have E. coli in it, another wound may have MRSA in it. They may not be the same pathogen, even knowing it's in the same patient. You want to treat them like separate patients. You want to make sure you get underneath the fingernails, because bacteria can really get underneath there and start growing. So when you're scrubbing your hands, you want to make sure you get underneath the nails as well. And that usually, if you're really doing a good job, should be about a minute scrub if you're doing all the fingernails and things like that. Universal precautions we use on everybody. If you only use it, say, with HIV patients, you are actually being discriminatory by doing that. You want to use it on every patient. And you really don't know if a patient maybe has hepatitis or has HIV. So that's a reason for really using universal precautions on everybody. And you really need to use them if there's leaking body fluids of any sort, there's an open wound, all that can cause potentially an infection. Fluids can cause that contamination. If you're not applying it to all the patients, it is discriminatory, and there have been lawsuits about that. Also, too, if we treat all patients with universal precautions, you really don't have to worry if the patient has HIV or not, because you're going to treat them the same way, which gets out of a discrimination issue. And there actually have been lawsuits brought under discrimination laws. Airborne precautions, measles and tuberculosis. Now, measles, most bacterial infections like that, most viral infections, fairly easy to decontaminate. Antiseptics and things like that do a pretty good job, because virus or bacteria, and viruses are more fragile than bacteria is usually. If it dries out, it pretty much is no longer viable. If they leaked on something, that body fluid, if it just leaked onto something, once it dries, most likely that has killed the bacteria or the virus. A little bit of disinfectant usually does a pretty good job of controlling most of those. If you really want to totally decontaminate an area, it may take 45 minutes of soaking in a solution containing an antibacterial solution to really totally decontaminate the area. TB, on the other hand, is another ballgame. Tuberculin bacillus, and it is a bacteria, but it's got a shell around it, almost like a spore, almost like a fungal infection. And a lot of the immune system can't get through that shell. It's really hard to get through it. Even antibiotics, it's hard to break its way into to really destroy the tuberculosis. Tuberculin bacillus can survive in a dry environment outside the body on a surface for up to 2 years, which is a long time. It's not very fragile at all. To decontaminate it, we're probably looking at not 45 minutes of a solution. We're looking at close to 24 to 48 hours of decontamination. Gas decontamination really won't work on TB. Basically, if we're working with a patient with active TB, which is contagious, whatever equipment you want to bring in to their room to be able to work with them stays in the room. And incineration is probably one of the best ways to get rid of the tuberculin bacillus. So disposable stuff. You don't want to bring your interferential stimulator in the room, for instance. You want to be able to have something that's there. Also, when they cough, there is sort of a droplet that can contain some of the bacillus. So you want to make sure you're wearing a gown completely. You're probably wanting to wear a hat or a hood. You may want to be wearing a faceplate so that bacteria can't get into you. If you're there for, say, 20 minutes, a regular mask will work. But if you're over 20 minutes, you need to have a respirator on. Ebola is the same thing. So you don't take in that pathogen in your body and develop an infection yourself. Or even you could develop an infection, but it's not very significant to you because your own immune system is fighting it to some extent, but you maybe could transmit it to other patients and cause a cross-contamination. You would gown and glove, booties, pants, things like that outside of the patient's room, walk into the patient's room, work with them. Then when you're going to exit the room, there's usually a trash can or something like that where you can take off your gown, gloves, or your gown. Actually, the mask comes off first. The hat would come off second. The gown would come off third, the booties and everything. Your gloves come off last. Your gloves are probably the most contaminated because you've touched the patient with your hands. So it's likely to have more bacteria on it. But you would actually leave it by the door before you exited the room. They're usually in a negative pressure room too, which means all the air is sucked into that room and then out through scrubbers into the environment. But that air is not put back into the regular hospital airflow. It's immediately dumped to the outside environment. And they're called negative pressure rooms. So that would trap the bacteria within the room and force it through the scrubbers. That prevents the bacteria from actually getting out of the room. Somebody with MRSA or something like, or a respiratory infection of some sort, if you take them out of the room, you may want to have a mask on them. So if they cough in something, they're not going to disseminate a lot of bacteria in the hallway or around and cross-contaminate other patients. They probably should also have gloves on when you take them out of the room. When they're in the room, they don't need the mask on. And the room will be contaminated, and you wouldn't want to put another patient in that room because they're at risk for developing whatever infection that one patient has. So there'd be probably a single person room. They put me in a negative pressure room when I first went in the hospital because they weren't sure what was causing my pneumonia. And I had way back in '89 been infected with TB. So they wanted to make sure that was totally negative pressure room for a day and a half until they were sure. Contact precautions, usually only if you're going to be in contact with the wound itself. Do you have to have gloves on? If it's going to spatter, you probably need to have gloves on. You probably need to have a face mask on. We get into this with doing wound care and things like that a lot. You don't want to have skin-to-skin contact with the open infection because that bacteria could get through your skin possibly. Not too likely because your skin has pretty good defenses, but it may not be perfect. And it can be absorbed through, some bacteria can be absorbed through the skin too. There are potentially a lot of questions on the exam over the safety and protection, and it could make the difference between an okay answer choice and the best answer choice. So I'm going to say good night to you guys. Bye. We're not really looking for you to read injuries.